Okay. All right, so we're going to start part 2 with putting it into action, power of precepting. And what we will address in this segment really are the two final points of instruction models and techniques that are useful in facilitating clinical learning. And then finally, how do you evaluate performance in the precepting experience? But before we do that, I promised I would improve that slide on the previous segment, and here it is in terms of how you know you're dealing with a self-directed learner, or how you know if you yourself are a self-directed learner. We are able to identify our own educational needs, and we're able to do that with a great deal of honesty. Number 2, not only can we identify our needs, but we know how to prioritize them, meaning we know what the critical path of learning is. Number 3 is we can set our own expectations of what that learning needs to be and what it needs to look like and how it needs to occur, which means we know what type of learners we are, whether it be kinesthetic, auditory, or visual. We can plan our own learning activities. We're really good at knowing how to identify the resources and the people and the atmosphere and the application of that learning. We're very flexible in that we can use different methods to learn. And then finally, I think I did make this point previously, we can accurately evaluate progress towards our goal. Now, when I say accurately, that tends to shift in two directions. Either some people have an inflated sense of self-awareness that's just not right at all, or people tend to undervalue the progress that they've made. Self-directed learners, excuse me, have a good sense of self, and they know how to do that. So, moving into techniques for good clinical learning. Again, I mentioned in the previous segment, I'm a fan of Dr. Medeo's, and he has published an article that outlines clinical precepting as this lovely acronym he invented, team leader. And these are just some general guidelines for supervising and teaching. On the team part, take charge of your group. Again, he's got some things published that really does promote a group precepting experience rather than an individual, which calls for you taking charge of the group. As we said in the orientation, the value in explaining the expectations, duties, and objectives of the learning experience. Accepting your responsibility to teach and evaluate. So you're the preceptor, and when you sign on to be a preceptor, I really can't overstress this point, you're signing on to be a mentor, a nurturer, a teacher, an expert. So you're signing on to help develop someone's skill set, and then at the end of that, make some statement about their competency. That's a huge responsibility. And then manage the workload and the workflow. Of course, all this has to be integrated with your day-to-day responsibilities, unfortunately, and also making sure that there's a balance, that the students have enough to challenge them, but not so much that it's insurmountable and affects their ability to learn. On the leader side, some of these are reinforcements. Lead by example. Certainly, you're going to be the litmus for them. You're going to be the mark by which people say or make some sort of statement about this is what a nursing professional is, or this is what a radiology tech professional is. You're going to be it. So leading by example is essential. I love number E, the explain your thought process. We're going to talk about this a little bit deeper in just a moment. But those of us who do a lot of thinking and we internalize a lot, we're not really good at transparency. You're going to have to, as a preceptor, learn to not just demonstrate visually, but talk through and explain not just how you're doing something, but why you're doing it and what the antecedents are behind those behaviors. Assess and address the needs of the learners. We've discussed that. That goes back to the self-directed learning goals. Demonstrate procedures during the coach method. Dr. Medeo is a big fan of coaching, and coaching has become very popular in the literature. There's a number of examples in literature, especially even among healthcare administrators, the value in coaching rather than teaching. Evaluate often and provide instructive feedback. And then finally, acknowledging your own limitations as a professional. Here's what I'm weak in. And being able to help the learner find ways to overcome or address the deficiencies that I may have as a learner, which is why in my class I bring in a number of guest lecturers, because I just know that I can't know everything about everything. So I try to compensate for my own deficiencies. So principles for clinical learning. There are 5 that Dr. Medeo promotes, and we'll go through these in a little more detail, but there's modeling, feedback, the climate, clarity, and practice to codify the learning experience. So let's talk about modeling, because I think this one, of all the ones, probably comes the most natural to health professions preceptors. And modeling occurs when you are demonstrating a skill, literally demonstrating a skill. So what happens though in modeling, it becomes job shadowing and it becomes direct observation, and certainly that's helpful. But from a clinical training perspective, going back to the E in leader, you've got to break out these steps discreetly. And you've got to give the rationale during the demonstration. So it's not enough to say, here's how we draw blood. And you take the syringe and you pop it in and you pull it out. You've got to break it up into discrete steps and talk about all the steps around that, the rationale for why you're doing something. I even like to talk about here's what could go right, here's what could go wrong. Modeling has been a great technique to use now in simulation training. Perhaps some of you are a part of the simulation centers across the state. They really provide a nice environment for modeling. The thing that I would encourage you to do is think out loud. When you're modeling, you want to talk your students through it. Here's what I'm doing. Here's why we're doing it. Because they cannot read your mind and they cannot appreciate the complexity of the steps just by watching you. So, I'm sorry, I was getting ready to advance prematurely, but the professional behavior I want to emphasize here is that no matter what you're doing, you cannot not teach. Students will be observing you every step of the way. So just know that even when you don't think you're modeling, you're modeling. Practice makes perfect. We've said this in the previous segment. Students their learning is going to be enhanced when they can apply something. So letting them practice is paramount to locking in a competency. So in terms of the clinical thinking, this is what I fear gets lost when we turn students loose and let them do things, practically speaking. We either give them an affirmation that they did it correctly, or we offer feedback on how to improve. What we never or rarely do is ask them to problem solve. And I think the worst mistake that can happen is a student do something right and he or she not know why she did it right. So as folks are practicing in your precepting experience, I think it's important to ask probing, problem-solving questions. So let's go back to the phlebotomy student who just drew blood. Okay, and then I would add, and they did it correctly. I would go back and ask, okay, what would you have done differently if you had missed the vein? How would you have gone back to correct? Or worse yet, say they inadvertently dropped the needle or they pricked themselves. What would you do next? because there are an infinite number of scenarios that can happen in the patient care experience that you won't cover a quarter in the precepting. So that's why using problem-solving questions as a part of practice is so essential to make sure that 360-degree learning experience occurs. The climate. We've talked a little bit about attitude, and you're bringing some energy and enthusiasm to this experiential learning process. This is what we're talking about when we're talking about climate. The personal rapport cannot be underemphasized. You've got to know who they are. You've got to have that relationship. There has to be a mutual trust, support, and respect so that you feel comfortable giving the feedback that they need, and they're comfortable receiving and asking for the feedback that they need from you. I like this quote on the learning environment, the teaching tip: recognize and capitalize on teachable moments. As a preceptor, this may not come naturally to you if you're a beginner preceptor. Maybe it's much more natural for the more seasoned preceptors. But you need to learn to cultivate your own sense or your own intuition of what teachable moments are. If you're a parent, you know when the teachable moments rear their ugly head. It's when you see something that you think needs to be corrected. And I would encourage you to look for those teachable moments, not just in the patient care experience, but in the professionalism as well. Looking at attitudes, perceptions, ideologies, looking at those as teachable moments as well, cultivating that sense of camaraderie and collegiality, both in an interdisciplinary way as well as a single professional way. Those are teachable moments as well. But healthcare, I don't think we would be in disagreement that healthcare would be a much better place if our mutual respect was certainly heightened. Clarity. And clarity usually comes as a part of giving good feedback. The slide here says an individual is more likely to learn when they have a clear understanding of the objectives and performance expectations. That goes back to the orientation. Focus the attention of the learners. Sometimes we set such high expectations and such lofty objectives that the student can get overwhelmed. So just know, as a point of clarity, it's okay to break those objectives into little mini sessions. We talked about in the modeling, I'm going to go back to the modeling, that you need to think out loud and break things into discrete steps. Clarity just reinforces that. Less is more is the quote here. And it's okay to beat a horse to death on one point just to make sure that that competency is achieved. And that leads to the feedback. Feedback can be very difficult. If you're not a manager, if you're not a supervisor and are unaccustomed to giving performance measures or performance feedback, it can be a little overwhelming. There's two types of feedback I want you to be aware of, and we're going to talk about this shortly in greater detail. But there's formative, which is more guiding feedback. This is when you focus on the performance and not the person, and you comment often. Good job. You can also think of formative feedback as coaching. Great job. Here's how you did this well. Here's how you can improve the next time you do this. The summative is more of the grading. So at the end of the precepting experience, this is the performance review. And this is when you involve the person in their own self-evaluation and coach them during self-evaluation. And we'll talk more about that shortly. Let's talk about a model of feedback. There are several ways to give feedback, and this comes from a publication that I really liked, A Practical Guide to Clinical Teaching in Medicine. Now, while it is directly written for medical students, it has much broader applications and certainly appropriate for health profession students. But as we have just discussed, through the modeling, through the clarity, you need to, and through the orientation, define behavior in observable and measurable terms. So when you're working up that learner's contract in orientation, make sure that you have written the objectives in a way that are achievable, they're discrete, they are measurable. That leads you to step 2, that they're written in ways that there are ways other than just direct observation to support that person either achieved or did not achieve a competency. So anyhow, so you're defining what the behavior is that you want to measure, and then you define your expectations. This is part of the formative feedback process. In step 3, is there a difference? That's when, went the wrong way. That's where the formative feedback is so important. So here's what I expect. Now, did I observe it? Is there a difference? And if there is a difference, you have to ask yourself, is the difference important? Sometimes I fear that preceptors will evaluate a student's performance based on their own style. Did they do it the way I want it done? Which may not be important. And if it's not important, then don't worry about it. If it's not going to make a meaningful difference in patient care, then it probably isn't. Remember, we're not trying to create a clone of you. We're trying to invest in a prospective health professional. If it is important, and oftentimes it is, if it is important, then I think you have to ask yourself, step 5, what specifically about that behavior needs correcting? And determine what the causes of that behavior are. Usually it's one of those 4 things. The learning deficiency can be attitudinal, maybe they just forgot, or they never acquired the skill to begin with. Perhaps the skill that they are needed to perform that behavior is an antecedent that never got addressed. So that's very, very important. So step 7 is you intervene and negotiate contracts for correction. So I expected you to do this clinical behavior, and I expected you to do it in these ways. Here's what I observed, a clinical competency deficiency, and here's what caused it. So let's negotiate how we can address this deficiency so we can check you off as having achieved this competency. And you can see there's a list of ways that you go about doing this. There's ownership of it. Nothing drives me crazier with students. This is my own personal disclosure. Nothing drives me crazier than when they deflect. Now, granted, sometimes it is my fault, but sometimes it's theirs. And I find that we can both overcome, this is when I guess I've become a fox, maybe an owl, that we can move forward with correcting this thing if we both own that perhaps as preceptor or instructor, I did not adequately convey the importance or the value of this skill, and you did not, as the student, adequately engage in a self-directed learning exercise to grab hold of that skill and practice it sufficiently, or give me the feedback that I needed to help you as the learner. So it is a shared ownership of the gap. You've got to make it performance-based. You'll hear me say this a few times. It can't be about the person, and I know that the folks watching this are all professionals, and you know that. It's got to, all your comments need to be based on the performance. Try to avoid you. You aren't doing this, you aren't doing that, but phrase your feedback more like, I observed this behavior when you did this. That makes it a little bit better. Well-timed. This is essential in formative evaluation. It's only a formative evaluation if it's done in a guiding, instructional way, which means it's well-timed. I hate to use such a derogatory metaphor, but I have a miniature dachshund. Mini Doxies are the devil to housebreak. And we went to school to learn to be housebroken, and I realized early on in our training that it was me who was being trained and not the dog. That as soon as she pops, I'm supposed to encourage her and cheer and give a treat. Otherwise, if I wait too long, there's too long of a gap. She doesn't know what she's being rewarded for. I am certainly not equating students to my miniature dachshund and housebreaking. But it is similar in that learning occurs, at least with positive reinforcement, when it's done in a well-timed way. Otherwise, there's too much other learning that occurs that can convolute that reinforcement. So timing is important. I've already said this, describe and not label. Here's what I saw. It should never be worded, this is bad. What you did was bad. It's, here's what I saw you do, and this is not the competency that we would expect. This is how you should do it in order to achieve the competency. And brevity and goal-based cannot be understated. Saying things in a long lecture format, you'll lose your audience really quickly, and I fear I've probably done that in this presentation. But saying it once, being brief, is essential. And then to stop and listen, get feedback, hear from them, hear their frustrations, hear their concerns, hear their insecurities, and use that as a part of teaching enhancement. That will make them feel better. It'll certainly enhance the rapport that you have with the student. And then finally, step 8, readdress the issue at a prescribed time, just to make sure that that correction is not lost. You just want to continue that reinforcement. So let's talk about teaching strategies. This is the fun stuff. This is how you function like a preceptor. These are some techniques, and there's many others you could use, but these are some of the commonly used ones that you'll see that are very similar from the clinical learning aspects that Medeo presented. And there are 8 of them that we'll talk about. Confidence building, confrontation. Remember, we like conflict. Conflict is not a bad thing. The mini lecture, sharing on a personal level, questioning, brainstorming, use of resources, and finally demonstration or modeling. Confidence building. We used the term coaching in a previous slide. I would consider this to be coaching as well. And I'm sorry, you just get to see my face. What I like to do is engage a group and do a little role play. I realize the adult learners will just soon dive and do role playing, so I will be sparing you from that during this segment. But I love confidence building, and the reason I love confidence building is because I get so excited about learning, and when I see my students get excited about learning, it just, a synergy comes about between me and the students. It's a wonderful thing to observe. So the way you use confidence building as a teaching technique is really exploit and capitalize on those teachable moments when they do something right. When they do something right, you absolutely need to celebrate that. That will begin to make them feel good, because there's going to be times when they feel vulnerable and insecure, and they're going to be afraid to step out. And it's in those moments when you can say, now listen, you've done so well in these other areas. I know based on previous experience, you're going to be an exceptional nurse leader, an exceptional rad tech. You can do this. And I know you can do this because you've succeeded in all these other ways. They need to hear that type of encouragement. I need to hear that type of encouragement. There are days when I feel like I just can't carry the world on my shoulders, and that's when I need my little text messages from my husband or my parents giving me the reaffirmation I need to go on. That's your role as a preceptor, a mentor, a nurturer, to be an encourager. Now, I will caution, you should do that with all sincerity. And if you think there's a chance that they can't do it, then you might not want to pick that moment to use confidence building, because then you start to lose your, they become a little less trustworthy if you use it so haphazardly or in a cavalier way. That's the word I'm looking for. If you use it in a cavalier way, then confidence building loses its punch as an effective teaching tool. Confrontation. Now, we've already talked about conflict resolution. Confrontation, remember, is a good way to teach. It is literally the identification of a gap, a discrepancy between behaviors or verbalizations or attitudes. Here's what I think you wanted to do, and here's what you did. Rather than calling them out in a derogatory way, what you do with confrontation as a teaching technique is you say, okay, here's what we needed to do, here's what happened. Let's reconcile. What went wrong? Tell me what you think. Tell me what you think didn't work out for you and how you do it differently. You don't solve the problem for them. You confront them by drawing their eye to the discrepancy, and in partnership, you all work through conflict resolution. The mini lecture. Preceptors like to do this because honestly, it's an easy, comfortable thing to do. And this is where you just keep a brief message short. You keep it short, you keep it on the point, and try not to stray into other life's lessons. A mini lecture literally lasts no more than 3 minutes. That is your time. Students like it. And you certainly can't help but use it. That's just the natural way we teach. But try to use it in a evenly distributed way, meaning don't use a lot of mini lectures on a lot of different topics up front. You kind of want to integrate it throughout the course of the experience. Speaking of experience, another thing that preceptors like to do that's very effective is share. And this really gets to the heart of building the rapport, building the relationship. And this is describing your own personal experiences, so long as it has a direct application to the teaching moment. It's often used as an illustration. So going back to that confrontation, you have a discrepancy. The student did something wrong. After you have worked through and reconciled that discrepancy, it's okay to come back and say, you know, here's how I did it, and this is how I did it wrong, and this is how I kept from doing it wrong again. You don't want to get too personally and impose your personal experiences onto the student. But having that identification that things go wrong and things happen, I think builds rapport and it codifies the learning. Questions. So questions are often used in teaching, and I said in the previous slide that it's good to use questions. You want to probe them. The worst thing that can happen is for a student to come through a precepting experience, have done everything right, and it all be done by chance. You need to probe and ask the hard questions to make sure that the right thinking is behind the right behavior. It can occur that there be wrong thinking and still get right behavior. That doesn't mean you're going to get the right behavior every time. So questioning is good. But there are reasons for using questioning. Establishing the rapport. People like to be asked questions because it shows that you're interested. So as a preceptor, when you ask questions of the student, that tells the student, gosh, she's really interested in what I'm thinking or how I'm thinking. That shows a mutual interest and a mutual respect. We've already discussed the fact that it promotes thinking and causes and promotes self-directed learning and problem solving. I like number 3. It certainly works for me. Number 3 is it helps learners organize their thoughts. If you're not a linear thinker, and not everybody is, asking questions causes some linearity to come to the thought process. And certainly in a patient care encounter, there are sequelae to things that you do. Having those questions helps to compartmentalize. I do A, I do B, and then I double check with C. Number 4 goes back to the clarity in the clinical teaching experience, and it's used to correct inaccurate thinking. It also, related to that point, causes the learner to refocus and reevaluate his or her own rationale and logic behind approaching a particular patient care experience. And then finally, it's just a good review. Asking questions is a useful way to facilitate self-evaluation. Now, for something a little more comical, questioning has a rather dubious reputation called pimping. And this is not an Amy term. Pimping is an actual term used in med schools, although I hope it's not used anymore because it certainly takes on very different meanings. But many, many years ago, pimping was a way of teaching medical students, and pimping by definition is a rapid fire succession of really useless questions that are intended to frighten and intimidate and not promote critical thinking skills. So here are some examples, just for your own entertainment value, of pimping. Arcane points of history, such as who performed the first colonoscopy. Not a useful question to be asked during the precepting experience. And these are some other examples. And I say this comically, but I also say it seriously. You know, as the preceptor, you cannot take advantage of the fact that you have all the power, that you have all the knowledge, and it's through you that you get to check off a student's ability to progress to graduation or whatever their next phase in their education is. So if you're going to use questioning as a teaching technique, be sure you use it for the right reasons and not these long reasons that are meant to squelch productive learning. These next few are some of my favorites, and quite honestly, I like them because I find them to be creative, and I like to think I have a creative spirit. Brainstorming. I said earlier, there are only so many patient care experiences that you can structure a precepting experience around, but there are infinite scenarios that can occur. I like brainstorming because it allows you to broaden that learning experience. So you've got a patient who comes in, and this is an older gentleman who has end-stage renal disease, and he's been on dialysis for 13 years, and he's beginning to have a reaction to some of his non-clotting medications. Okay, well, what do you do? What do you do for this patient? There's certainly best practice scenarios that you can play out, but what are they? So you sit down and you talk about that one case and you brainstorm all the possible things that you could do, and you take each of those patient care opportunities down to the end point, and that one case then becomes maybe 6 different learning opportunities that the patient can think, or I'm sorry, that the student can think through in ways that he would never be able to think through in an actual case-by-case situation, because you just don't have that much time. I love that. There's a lot of literature, and please look this up behind me, called problem-based learning. Problem-based learning really exemplifies brainstorming, where you take all the possible things that could happen in a real-life case and you work through them, and then you have different options and different scenarios that your students can learn from. It's a lot of fun. It's a lot of work, but it's a lot of fun. Use of resources. We spoke earlier of things that you as a preceptor should model, one being lifelong learning, and the other is how you go about finding educational consultants and resources for learning. This is a teaching technique as much as it is an attribute of self-directed learning. So use the literature, use other professionals, find great resources, help them cultivate their own resource infrastructure for going and getting answers to questions that you don't have and they don't have. Demonstration, we've already talked about. Modeling is the other example of that, so I won't talk about this one anymore. I want to talk now as we wrap up and think a little more deeply about evaluation and feedback. We've talked about formative, we've talked about summative. Let's talk a little bit more now about the nuts and bolts on how you deliver a good evaluation. There's different sources of evaluation, and I said earlier you want to make sure you have a diverse database, or at least diversity in data sources of that evaluation. And these are just some examples. Certainly direct observation. You're going to get a lot of that through the demonstration and the modeling and the practice. The questioning, hearing their thought processes. Review patient notes and records. A lot of preceptors don't think to do this, but I think a great way to demonstrate evidence of competency is to look at the patient record. How good a job was the documentation? I also like to do presentations. I encourage my students at the end of a precepting experience to do a presentation of what they've learned, and the audience usually comprises me as the faculty, the preceptor that I have put them with, and maybe a patient or two to hear how that learning experience was, what they learned, how they learned it, and how they will take that information and build on it. That's a great way for you as the preceptor to observe how good a job you did at cultivating this experience. Learner self-assessments. There's instruments out there. Certainly your local university may have them. I'm pretty sure your AHEC partners will have that. But you want to look at and engage their own sense of how well they think they did. And then finally, talking directly to patients. What is your observation of the student? How good a job did they do relative to an experienced professional, and where do they need to improve? That makes patients feel like they're a part of the process as well. So this is from Dr. Lampkin, Meaningful Evaluation of Students by Preceptors, and these are just some guidelines for you to keep in mind as you're doing your evaluations. This goes back to the beginning of our first session, having open communication. You know, there's a bit of a power imbalance that's inherent to the preceptor-student relationship, meaning the preceptor has all the power because you are a part of their assessment pathway to getting their degree. So there is a bit of an imbalance that you've got to address. And the way you address that is making sure that you have open dialogue, that they know and feel that you're a partner in their education and not someone who is taking on an autocratic role, trying to trip them up, so to speak. So the communication is key. The second is making sure that evaluation is scheduled regularly. Again, formative, formative, formative. I like to tell people that if you have done a good job as a preceptor at providing great formative evaluation, meaning that's the guiding evaluation, the ongoing guiding, then the summative is just a mere obligation. The other thing I like to tell people is that once you have reached the summative phase, the grading phase, there should be zero surprises. The student should know, the preceptor should know, their faculty should know the degree to which that student has progressed on their competencies. If there are surprises, then you as the preceptor you have not done a good job. There should be zero surprises. Evaluation should be based on specific observable situations. Remember we said the learning objectives need to be discrete, they need to be measurable, they need to be performance-based and not person-based. All evaluations should be shared with the student. Again, that goes back to the formative process and how summative should not be a surprise. Guideline 5, the student, as we have said numerous times, should be an active participant in that final evaluation. And then one that I added to Dr. Lampkin's list goes back to the orientation, that there should be no surprises. The student should know what they're being evaluated on from day one. It's not fair to grade them on something that they had no knowledge that they were being assessed on, not because it's a trick, but because it's not been a learning priority for them. That's just not fair. So I wanted to make that point. So we've talked about formative and summative. Formative is guiding, improving learning. Summative is grading. It's assessing competence. You're collecting data. You are synthesizing the data from numerous sources. You're using those findings. If it's formative, it's to improve performance. If it's summative, you're grading. So that's all great, but here are some traps. And these are some traps I just want to make you aware of because they're pretty common, especially in new preceptors. The first one is reviewing another person's performance from an autobiographical perspective. Again, this is a list from Dr. Medeo's research. You've got to be cautious about assessing a student's performance compared to your own. You can't transpose your competencies onto the students. Now, having said that, there are key professional competencies that they have to be able to achieve just like you have to achieve. But their experiences are different from yours. You're in a different place. You're an expert. Remember that. They're not. So just keep in mind that and make sure you're not transposing your own experiences onto theirs. Number 2, another trap is being the target of responsibility ricochet. Be sure to give instructive feedback to correct mistakes rather than placing blame. And that responsibility ricochet can actually go both ways. The student can deflect or you can deflect. Remember, evaluation is all about improvement. I want to be a partner in your learning. I'm here to help you do better, not penalize you. So let's not get into the blame game. It's a mutual ownership. Number 3, basing judgment on extraneous factors. Remember, stick to the evaluation criteria. Don't throw in other things like, okay, well, I know that you have been really, really sick and that's impaired your ability to do this and that and the other. Listen, they either did it or they didn't. Don't throw in some other stuff that's irrelevant to the measurement. Number 4, putting all your eggs in one basket. I'll put it in common language. Your evaluation, the evidence of your evaluation needs to be diverse. We've already said that. You're going to be evaluating pretty complex competencies. So it's going to require a diversity of data sources, which means you're going to need to let them do presentations or demonstrate their skills. You're going to have to question. You're going to need to look at patient records. I like to encourage people to triangulate a competency. And by triangulate, that means you're getting a 360-degree view of that competency. You're getting it from your lens, you're getting it from the student's lens, and you're getting it from the patient's lens. If you capture it from all 3 of those angles, man, you can't do better than that. Number 5 is probably the most violated because if you're a preceptor and you love your job, you're just wanting to do good for all. And that's introducing the halo effect. It's the concept of social progression. Some students aren't going to perform well. And you can't let them graduate and you can't let them progress through their programs just because they're good people wanting to do good things in the world. It's a patient safety issue, if anything. And it's a fairness issue as well. So be cautious about hanging a halo on a student's head, and remember, you're assessing a performance, not a whole person. And then creating artificial barriers or obstacles. This isn't as common, but be fair, be firm, be positive, but don't make it so. Don't create an Mount Everest for people unnecessarily. So wrapping up both sessions, it all begins with orientation and cultivating that relationship, understanding their learning needs, understanding their conflict resolution styles as well as your own, is only going to enhance that environment. Making self-directed learning a priority, not just for the student, but for you as well. Adopting these team leader attributes, the clinical teaching tools and teaching strategies. And remember that evaluation is the assessment of a competency and a performance, not a person, and it should be done as soon as you meet the person, ongoing through the end. And that leads you to the end of your precepting experience. Here are some of the references that I've used. Certainly there are many, many more. These are just a few that you can use. In closing, I'd just like to close with 2 points. One is, if you don't have a formal precepting program in your organization, I would really encourage you to do that. And usually what that looks like is a team of you. Maybe many of you within your organization serves as preceptors, where you all can come together and develop some instruments, identify some orientation materials, and talk about your experiences collectively on how you can do things better as individual preceptors and how you can develop a precepting program as a group. Students learn better in an interdisciplinary way. If you can make that happen, more power to you. And the last thing I want to say is just as a word of gratitude. We have at any given time 44 MHA students in our own program, and I do precepting work with other clinical students. It's becoming more and more difficult to find professionals who want to precept, and I will wrap up with how I began on part 1, in that this is an awesome responsibility, and you probably came into healthcare wanting to make a difference in the lives of patients. But because you're an expert and because you're a consummate professional, we need you so badly in cultivating the next generation of healthcare professionals. I cannot overstate your value in this learning process and the leadership that you bring to creating a culture of having a strong work ethic, having lifelong learning, and self-discipline. You're the best teacher. You're a much better teacher than we could ever be compared to those of us in the classroom, and you just should know that you're supremely valued. And if I can ever be a resource to you or your organization, please don't hesitate to contact me. I can be reached through your local AHEC. I'm a great partner and great believer in the AHEC system, and so feel free to reach out to me or Dr. Medeo or Dr. Lampkin. They're great leaders, and again, thank you in all that you do.